Lokesh, now
Yes.
it is. Now it is.
Okay, thanks. Uh, so a very warm welcome to all the doctors, and thank you so much for accepting our invitation. And this is, I believe, our second session for Cases in Many Faces with Dr. Unikrishnan sir. And I'm really thankful on behalf of Mankind Pharma, Lokesh Ganju from the marketing team. I'm really thankful to all of you who have took your precious time and came for this meeting, and especially Dr. Unikrishnan sir, who accepted our invitation and agreed to do this program and spread knowledge in terms of diabetes and how to manage diabetes amid this difficult situation. So to begin with, about the presentation about our corporate. So as all of you know, the company started in the year of 1995, and I'm really proud to share that Mankind is one of the youngest Indian pharmaceutical company which has been able to be among the top 5 pharmaceutical companies in India. And the founder of this company has been Dr. Mr. R.C. Juneja, whose vision has always been to serve life in the best possible way. And we are ranked first in terms of prescriptions and ranked fourth overall in terms of values. But because of quality medicines at affordable price, we have been ranked, first in terms of prescriptions. Our revenue is approximately $1 billion US, and we have strong presence among across the therapies, let it be OTC, prescription, or even veterinary medicines. The philosophy of Mankind has always been serving life, and that core philosophy is based on 3 pillars: quality, affordability, and availability. So obviously we have been able to produce quality medicines and develop quality medicines at affordable price. That's how we have been known for. And those quality medicines at affordable price, we have been able to take it to each and every nook and corner of the country with our highest field force which we have in the company. And if I talk about the milestones, as I said, the company was launched in 1995. Then in 2007, we ventured into OTC and veterinary market. Then, we had an integrated R&D center. We established it in 2011. And with many of the achievements, we even started our operations in USA by 2017. And, we have been able to launch our first product in 2019 in USA. Right, so these are few milestones which we have achieved, all because of all of your support. And during these tough times, previous year when this pandemic first time hit the country of ours, that is India, we have been able to contribute 51 crores in PM Care Fund. Along with that, TP kits, more than 12 lakh sanitizers, and all these things we have been able to distribute. Apart from that, this year we have been able to contribute 100 crores, considering the kind of fatality which this particular event had on our country. So our company had contributed 100 crores towards the martyred doctors, paramedics, pharmacists, all who have been serving day in and day out, let it be policemen and all those people who have been serving day in and day out, to manage the disease. As I said, we have presence across multiple therapies, let it be anti-infective, gastrointestinal, diabetes, Nutra, Opthal, anti-allergic, so on, and with leadership in many of them. We have a well-established R&D center at Manesar, Gurgaon, where our core capabilities are new drug discovery, API development, biosimilars, analytical research, and so on. And it gives me immense pleasure to announce that Mankind has first time been granted a global worldwide patent for its new molecule, that is GPR11 for which we have already filed IND, investigation new drug, and we have got this patent till 2037. So hopefully, if everything goes well, by 2025 or 26, we'll be able to launch this molecule globally, which will be an oral form of GPR119. And obviously, we are really proud to say that, we'll be the first Indian company to do so. Now, all these achievements, all these pinnacles of success and everything would have never been possible without all of your continuous support. So we really thank you for your support and encouragement, and for being partners in care and to overall serve the society in terms of management of diabetes, or even in terms of serving during these tough times. We would continuously require your support. Thank you very much to all of you. Now with this, I would like to introduce our medical advisor, senior medical advisor, Dr. Prashant. And now, Dr. Prashant, over to you. You can introduce Dr. Unikrishnan.
Thank you, Lokesh, and thank you once again to all the participants who have joined us here for this educational session with none other than Dr. A.G. Annikrishnan, sir. Dr. Annikrishnan, sir, is an endocrinologist and CEO of Chelaram Diabetes Institute, Pune, which is a leading diabetes institute in India and an IDF certified center for education and excellence in diabetes care. He has published the largest multicenter study of subjects with pancreatitis and pancreatic diabetes worldwide. In addition to his many other publications, he has more than 160 in index journals. He has received the Subhash Mukherjee Oration Award of the Endocrine Society of India and the Srivastava Award of the RSSDI, which is India's largest diabetes society, for his contribution to diabetes in India. He has received the Jacob Memorial Prize for the Best Patient Care awarded by the Christian Medical College Vellore in 1998 and received Fellowship Award of the RSSDI in 2017 and the Dr. Sam G.P. Moses Oration Award by the Diabetes Association of India in 2018. Recently, he received Diabetes Excellence Award of Digital Diabetes Summit at Hyderabad in 2019. So, without wasting any other time, I hand over this session to Dr. Annikishan, sir. Sir, over to you.
Thank you. It's a pleasure being here, and I'm going to discuss a few cases. I thank Dr. Prashant Agarwal and the team of uh, Mankind and IJCP for facilitating this interaction. And I'm going to talk about diabetes management during the pandemic. So I'm going to begin with discussing some general aspects in terms of a case and how diabetes care has transformed during COVID, and then go on to some illustrative case studies. Dr. Prashant, I hope I am audible and my slides are visible.
Yes, sir. Yes, sir.
So let's begin with the case. A 55-year-old lady with diabetes. This is a case study on metformin, SGLT2 inhibitors, and dulaglutide. Because she is diagnosed to be COVID positive, the primary care physician has started dexamethasone, favipiravir on OPD basis, and of course, the usual other medicines. We are not here to discuss whether dexamethasone should be given or favipiravir should be given. I believe that dexamethasone has role only in hospitalized patients and patients who require oxygen, and in mild cases, it should not be given. We also know that the unnecessary increase in dexamethasone therapy and hyperglycemia is probably driving mucormycosis infections also. But I'm not going to discuss that because COVID management is not something that I can teach my colleagues, because I should be learning from physicians about that. But I'm going to talk about the diabetes. Now, her random blood sugar is 157. The urine ketone is nil. She is stable but reports mild fever and fatigue. So, should these medicines be continued? What should we do? Now, these were the guidelines published in Lancet for management of diabetes in COVID-19. So metformin is generally safe in mild disease, but sometimes dehydration and lactic acidosis can occur in sick patients. So in those patients, you need to stop metformin. During illness, if there is an ill patient requiring hospitalization on metformin, you should monitor the renal functions. But in general, metformin is safe. SGLT2 inhibitors include canagliflozin, dapagliflozin, empagliflozin. Again, in mild cases, you can continue, but in moderate or severe cases, there is a risk of dehydration, ketoacidosis. So follow the sick day rules. Of course, in respiratory illness, these drugs should be stopped and renal function should be monitored. So what about glucagon-like peptide? Now, this is different, but these drugs cause loss of nausea, vomiting. So as an endocrinologist, many of my patients are taking dulaglutide, liraglutide, and etc. So I don't like to continue when they do a teleconsultation or they contact me and tell me that I've got COVID. This is one group of drug I don't like to continue because already they have a lot of nausea, and because of COVID, they have loss of taste and smell. So their food intake can really come down and they can become weak. So I think as PP4 inhibitors can be continued, but GLP-1 agonists should be stopped. So coming back to this patient on metformin, SGLT2 and dulaglutide, dexamethasone should be started. I think blood glucose should be monitored. I feel patient has got just a very mild fever or maybe even mostly asymptomatic. Many people are asymptomatic. You can continue these drugs, but if the sugar rises, stop the metformin, stop the SGLT2. Dulaglutide anyway should be stopped. If fever rises and if sugars rise, you should stop all this and start insulin. If the patient is stable and some people's, dexamethasone, their sugars don't rise, you can continue therapy. But definitely, dulaglutide is something I would like to stop. Now let's look at new diabetes after COVID. Because of the ACE2 proteins present on the beta cell and the lungs, uh, people have found that uh, new onset diabetes can occur after COVID. And these are case reports from Delhi. First is a 30-year-old man with diabetes and COVID precipitated ketoacidosis and pneumonia. Second is a 60-year-old man with hypertension. Again, diabetes was precipitated along with a stroke and DKA. Both patients did well, and there are lots of case reports of diabetic ketoacidosis in COVID and new onset diabetes also after COVID. Now, I have seen two cases of type 1 diabetes after COVID and some cases of type 2 diabetes like disease after COVID. Some of the patients who don't have true type 2 diabetes, I have gone back because in some patients I've been able to stop medicines. I have gone back and seen that they had pre-diabetes before. So I'm not sure that I know that the COVID has an effect on beta cell and blood glucose levels increase, but whether there is a true new onset diabetes or HbA1c was high and undetected before, we don't know. But because of many reasons, the blood sugar level rises in COVID. One is the stress of infection. Second is the stress of the pandemic because even people who don't have COVID are thinking about it and getting worried. The use of steroids, damage to the beta cell of the pancreas, insulin resistance and cytokine storm can all occur, and other factors. So together, all these can produce hyperglycemia. So telemedicine has come up in a big way, and this is increasing. And let's look at, this is the problem in COVID is that patients are doing their blood glucose. Of course, this is not a COVID patient. This is a gestational diabetes patient who has to check their blood glucose levels continuously, and this is very difficult for doctors to interpret. Therefore, you have now glucometers which connect to the cloud, and patient does the blood sugar, and doctor can see it in his clinic. So this is a 33-year-old lady who presented with hyperglycemia during the first wave. This is a second wave, but during the first wave, it was a precious pregnancy after IVF. She had diabetes and blood sugar was 93 fasting and 225 post meal. She contacted us on telemedicine because she was afraid to come to hospital because of the pandemic. She said, I could not visit the hospital because I'm worried. So she did a video consultation. We started on metformin, and you can see these are not single blood glucose levels. These are mean pre-breakfast, mean post-breakfast, mean pre-lunch, mean post-lunch, mean pre-dinner, post-dinner mean. And you can see every day she was checking initially 6 times a day, then she made it about 4 times a day. With metformin, diet, and exercise, she delivered a healthy baby. And these were the 3 cases we published of tele-diabetology for management of newly diagnosed gestational diabetes, showing you that yes, with diet, exercise, metformin, and even insulin, you can manage lots of newly diagnosed GDMs who may be worried about visiting a hospital. This is another lady, a 50-year-old lady with diabetes since 5 to 6 years, and her sugars were high, HbA1c was 10. She was on aspart and glargine and vildagliptin and repaglinide. And what we did is uh, we increased the glargine aggressively on phone, and we controlled the blood sugar levels. And you can see that the blood sugar levels were very well controlled in this patient. This is another gentleman. Uh, he's a 33-year-old gentleman presented with an online consultation for a toe injury. He had type 2 diabetes for 10 years. He also has had peripheral neuropathy for many years. He was taking a combination of insulin and oral anti-diabetes drugs for diabetes. He monitored blood glucose levels regularly and visited a doctor. But now the toe injury was worrying him because initially he found an injury on the left big toe. He published this series of cases called the application of telepodiatry in diabetic foot management during the COVID pandemic. You can find this article online. So this during the pandemic, he self-dressed the wound because he didn't want to see a doctor with topical antibiotic cream. But while doing this, on the third day, he found the wound was oozing with a yellow discharge and he was far away. So he consulted the physician at our hospital through an online consultation. He described the incident and shared the image of the wound. You can see that we trained him to clean the wound, and this is a clean looking wound. We prescribed antibiotics. We told him to strictly offload. We gave a simple amoxicillin clavulanic oral antibiotic. We asked him to clean it with saline, and also we did a light gauze dressing, but told him, since he said, we told him you visit our hospital, but he said, doctor, I'm too scared to visit the hospital. So we asked him to show the wound daily and we asked him to offload. Now, offloading is the most important treatment of diabetic foot. It is not surgery, it is not debridement, it's not antibiotics. The most important treatment of a diabetic foot ulcer, especially in early stages, is to give rest to the wound. Rest is called offloading. So in these patients, we told him, make sure your leg does not touch the ground. With that, you can see the wound really healed very well. And his wound became ulcer free. So we were able to manage this infection online. We told the patient you should come to hospital, but they said, doctor, we can't come, we are worried, we are scared of diabetes, etc. etc. Now, this is another patient who came to our hospital. We found our hospital online. And you can see this is already a high risk foot. Why do I say this is a high risk foot? Because you can see there are two toes are missing. He has already had amputation of the two toes. And this is the area of maximum pressure of the foot. Because of the neuropathy, because of the flexion of the metatarsophalangeal joints, the ball of the great toe is the area at which there is maximum pressure. And you can see because of this pressure, a callus has formed. And because of the callus, he has been walking on the callus, and infection has occurred, and there is a pus collection underneath it. There is an abscess. And you can see that the abscess has, even in this picture, you can see redness here, redness here. So the infection has spread almost up to here. So we told him to visit the hospital. And once he visited the hospital, our surgeon opened it, drained all the pus, and we did daily dressings and we sent him home. Now, from home, we followed him up on telemedicine. And on telemedicine, with offloading and antibiotics, you can see the wound healing and you can see a completely healed wound. So this is to say that most people with diabetic foot, especially cases like this, have to visit a hospital. But telemedicine can identify the low risk cases from the high risk cases. In the first case, I showed you a low risk case, which can be managed at home. In this case, I'm actually showing you a high risk case. Patient came to hospital, the wound was drained, the pus was drained. You can see the wound healed completely. And then the post-operative follow-up can be done at home because patient may find it difficult to keep on coming to hospital every day. So that really healed. So I showed some cases. I'm going to show you just my last case or so. This is just to show you that telepodiatry can be used for trialing. This is another patient who contacted us. This patient had taken help in a local hospital, but the wound was not healing. When we saw the wound, you can see there is a large ulcer in the wound. So they say that diabetic foot is like the tip of the iceberg. Underneath this is looking dry, but underneath that, there is a lot of pus. So this is one of the limitations of telepodiatry, because by telepodiatry, you cannot make out what is underneath. If you look at this picture, it seems to be a healing wound, but actually it is a dried eschar here, and underneath that, there is a huge abscess. But when this patient came to us on telemedicine, we said, no, we cannot manage you on telemedicine. Please come and visit the hospital. And once he visited the hospital, there was a large pus collection. As you know, some people say that heel ulcers cannot heal because there is the Achilles tendon. It is difficult to do offloading because the ankle is always dorsiflexing and plantar flexing. And then he underwent surgery. After surgery, you can see there was a lot of slough. The surgeon put some sutures to keep the wound closed, and we opened it at times. And our podiatrist team kept on doing daily bedside dressings and removing the slough. And after that, when the wound started healing, we removed the stitches and left it open. Again, some pus came, but then you can see the red granulation tissue started forming. And later on, the wound looked very clean, and this patient was followed up again on telepodiatry, and you can see the wound healing very well. So, some of the limitations of telepodiatry is that in telepodiatry, you cannot make out the depth of the wound. Second, there are some apps which will tell you that the wound is red and inflamed and all that. Really, it is very difficult to make out cellulitis on photographs or on softwares. The third thing is whether the wound has invaded the bone. You have to put a probe and look for osteomyelitis. That is difficult. So telepodiatry is actually a very risky affair, and I don't recommend it at all. But sometimes patients says, doctor, if you don't treat me on telepodiatry or on telemedicine, then I will not get any treatment. My foot will go. So please treat me. In those situations, only you can treat. Otherwise, patients should always, try always to visit the hospital. So I think telepodiatry has got a lot of limitations, but definitely, we could save a few lives during telepodiatry. But as I said, there are people publishing hundreds of cases of telepodiatry treated. But friends, it is not at all easy. So these are some guidelines we develop for telepodiatry management. The online appointment is fixed, and once there is an online appointment, the patient has to share all the medical records, X-rays, photographs, cultures, antibiotic list, diabetes management list, blood glucose list. Now, on your website itself, you should take appropriate consent. And then, if there is a diabetic foot problem, which is stable, like minor arthritis, minor injury, just neuropathic symptoms, ideally, you should tell the patient to visit the hospital. Now, if it is possible, let the patient visit you in the clinic and go for appropriate therapy. Now, sometimes patients will say, no, it is not possible to manage on telepodiatry. I mean, it's not possible to come to the hospital. Then you will have to manage on telepodiatry. Patient says, I can't come to hospital. Hospital is far off. I may not be able to visit the hospital. I am an old person. Nobody is there to take me. Doctor, I'm worried if I'll get COVID, so I will not come to hospital. So in that case, you can manage like I showed you for online consultation. These are for mild cases. Now, complicated cases, if there is sepsis, there is ulcer, there is necrotizing fasciitis, if there is acute Charcot neuroarthropathy, then it is important to visit the hospital, hospitalize the patient, and appropriate management. Now, as I said, once you have done the surgery and the wound has started healing, you can go back to telemedicine. Also, telemedicine can be a good triage to separate out the stable patient from the complicated patients requiring emergency and urgent admission. So, friends, this is the ICMR, Indian Council of Medical Research, 2021, just very recently published. It's updated. Earlier government came out with some telemedicine guidelines which were not updated. But now government has come with a framework. The ICMR has come with a framework for telemedicine use in the management of cancer, diabetes, cardiovascular disease, and stroke. This is available as a free document online, and you can always find it online, the whole resource. And I was also happy to be part of the group for making these guidelines or framework for telemedicine use in diabetes. So essentially, whatever I showed you, I tried to show that low risk patients you can manage, but make sure that all the diabetes related tests are done, that wherever possible, you are looking for complications. And diabetic foot, I also suggested how diabetic foot assessments can be done. And I think this you will find is a useful document. So friends, as I said, these are the stress of infection. Infection itself can cause the release of cortisol, glucagon, epinephrine, growth hormone, and all the stress hormones. These stress hormones can block insulin production and insulin action. And when they block insulin production and insulin action, you can get hyperglycemia. These days, many people have intense mental stress about the pandemic. They call it doom scrolling. People are going on social media and keeping on reading bad news, or going to website and keeping on scrolling and reading bad news about the pandemic. They are keeping on looking for good news, but their eyes are attracted to bad news and they keep on reading it. They get stressed, insomnia. Remember, the stress itself is not good. It can precipitate hyperglycemia. Steroids, as you can say, very commonly, steroids are associated with hyperglycemia. And many of my patients who are contacting me for telemedicine and are having steroid induced hyperglycemia. With the impending occurrence of mucormycosis in India, some of my suggestions, who I am not a physician like you, uh, I think dexamethasone should be used only when required in moderate, severe cases which require oxygen, not in mild cases. The minimum dose of steroid should be given. If steroids are given, always try to manage the patient with basal bolus insulin. Of course, looking for some restriction of eye movements, tenderness over the maxillary area, uh, pain in the eye region, any redness in that area. Looking for subtle signs of mucormycosis is important. Some doctors have believed that unnecessary iron therapy leads to mucormycosis. I'm not very sure. But many years ago, in 1996, when I was a lecturer in endocrinology at the Christian Medical College, Vellore, I used to see mucormycosis in type 1 diabetes patients who have diabetic ketoacidosis, and those were very serious cases. Also, in certain cases of bone marrow transplant patients requiring desferoxamine, secondary hemochromatosis, many of these patients developed it. So there is a very strong link between iron metabolism and mucormycosis. I'm not the exact person to tell you what the link is, but control of blood glucose levels, reduction, controlling the infection, because infection can also cause ferritin release, uh, preventing oxidative stress, and of course, new research, early diagnosis and treatment may also help us to fight the impending epidemic of mucormycosis. As I said, the beta cells of the pancreas express ACE2. And ACE2 is one of the proteins which bind to the spike protein of the coronavirus. So therefore, there is a theory that diabetes can cause beta cell failure, and COVID can cause beta cell failure and result in new onset diabetes. Well, if you see a patient with diabetes after COVID, I really request you, as I showed you the cases, to go back and just see if there is a history of pre-diabetes before and diabetes before. If you keep on asking question, patient will say, हाँ 2 साल पहले मेरा एक blood test किया था, अभी मैं दिखाता हूँ डॉक्टर साहब, and then they pull out their mobile phone and show you 2 years ago HbA1c was 6.8%. So many of these cases may not be through COVID-induced new onset diabetes. They may be undiagnosed or unrecognized pre-existing diabetes, and many people may have pre-diabetes also. Having said that, there are a group of patients who have hyperglycemia post-COVID. Remember the insulin resistance syndrome and the cytokine storm syndrome, which causes insulin resistance. All these can worsen hyperglycemia. Of course, there may be other factors which we still are coming to know about. So friends, I've come to the end of my presentation. I showed you some general cases of COVID and diabetes. I showed you a lady who had COVID and diabetes on dulaglutide, SGLT2 and metformin, and mild fever and fatigue. And I discussed how to manage. And when dexamethasone is given, you'll have to shift to basal bolus insulin. I showed you the management. Then I showed you how diabetes has transformed during the pandemic. I showed you initial management of newly diagnosed gestational diabetes on telemedicine and our published series. I showed you how basal bolus insulin therapy and dose adjustment can be done and blood sugar controlled remotely. I also showed you some other case scenarios of diabetic ketoacidosis precipitated by COVID-19, and I discussed our experience with telepodiatry in the management of diabetic food during the COVID pandemic. I ended by showing you the ICMR guidelines for telemedicine in diabetes, for which I was also a member of the ICMR guidelines team. I'd like to take this opportunity to thank you for listening to me. And if there are any questions, I can answer them. And I also have now started posting important articles and information related to diabetes in the pandemic on Twitter. So if any of you are on Twitter, please feel happy to follow me and on Twitter and discuss the ongoing pandemic with me. Once again, friends, these are difficult times, and we as doctors are at risk of COVID. So be safe, keep your family safe, try to remain positive and happy, and then we can help all our patients. But I think that things eventually will get better, even if they temporarily get worse. And I urge you to remain positive during the pandemic. It's difficult, but that's one of the ways to help each others out as medical colleagues and also to help our patients is to remain positive, uh, enjoy the small moments in life, spend time with friends and family, and like this, be in touch with all of us virtually. Once again, it is a pleasure being here with you. Though I used to give a lot of talks in a lot of conferences uh, on a face-to-face basis, this is an opportunity where I can meet you all virtually. And I'm grateful for the organizing team for giving this opportunity where I can meet with all my dear colleagues, at least on this virtual podium. Over to Dr. Prashant for any discussions or questions that may be there.
Thank you, sir. Thank you so much, sir, for this wonderful presentation. Now, I would request all our participants, please, one by one, if you have any questions to ask, please unmute yourself and you can ask. Or you can write down in the chat box also. So, there are actually two or three, four questions on the chat box. So, first is, drugs to be used during COVID infection in diabetes patient, and which drugs we should withhold. Sir, you are on mute. Yes, sir.
Sorry. So thank you. And in the early stages of the pandemic, especially during the first wave, there was a position statement published in Lancet. That position statement said that you should not use metformin because many patients with COVID are presenting with diarrhea, and SGLT2 should not be prescribed because it causes ketosis, and GLP-1 should not be prescribed, and only prescription is possible for DPP-4 inhibitors and maybe sulfonylureas. But nowadays, the number of cases is so high, and many patients are asymptomatic. And in asymptomatic and mild patients, I prefer to continue all these drugs. The only drug which I don't like to give at all is GLP-1, which I always stop because a lot of nausea and vomiting can occur. And whenever the ketones are positive or when dexamethasone is given and sugars are very high, I stop SGLT2 and metformin. But in mild asymptomatic cases, you can continue. Now, in the third situation, whenever you are in doubt in moderate and severe cases, you have to give insulin. The way to give insulin is basal bolus therapy. Now, if you look, there are many people saying that why don't you use NPH insulin because NPH mimics the physiological profile of prednisolone and methylprednisolone. Yes, I agree that it can, in hospitalized patients, we use NPH in steroid-induced diabetes because NPH profile mimics the glucose profile of methylprednisolone and prednisolone. But in a home setting, it is very difficult to prescribe NPH. It's not very practical uh, because even if you give NPH, once its action goes off, you will have hyperglycemia. So, if a patient calls you from their house and if you're thinking of basal bolus insulin, the best thing is to tell them to do a fasting. And if fasting is high, to start a small dose of glargine. And after you have given a small dose of glargine, the post meal is high, you can give short bursts of short acting insulin as needed. But get some glargine on board is my suggestion during this period because that's the most practical. Even in steroid induced hyperglycemia, it helps because if you require it for 3 or 4 days, it's very difficult to manage NPH for patients at home. And giving NPH just before methylprednisolone, these are all practical in a hospital setting. So this is my suggestion for management, but we can take more questions as time goes by.
Thank you, sir. So the next is, I mean, related to oral medications. So, doctor, I wanted to just know about the role of gliptins because, sir, last year I guess I remember, sir, there were a few papers which suggested that gliptins might have some role as an anti-inflammation or anti-inflammatory also in COVID cases. So, what is your point of view, sir?
So look, I think if you ask me very personally, I don't think DPP4 inhibitors are a treatment for COVID and it reduces inflammation and all that. Most of it are in vitro lab-based phenomena and not really in clinical practice. But having said that, if you ask me, Dr. Undi, which is a drug you feel is most smooth in COVID, it has to be DPP4 because whether it is vildagliptin or linagliptin, any gliptin it is, it doesn't produce hypoglycemia. It is not associated with much hyperglycemia. It's easily tolerated. Yes, when you give steroids, there is a risk of steroid induced pancreatitis, and steroid induced pancreatitis can be worsened by gliptins. But for a short period, if you use gliptins, which many gliptins are not at all even associated with pancreatitis nowadays. So I think my default choice is always DPP4 inhibitors in mild or moderate cases. And even in severe cases, sometimes if you have no choice and if you are struggling with insulin, you can manage it because all this dexamethasone and all only maybe for a short period. So my choice is DPP4 inhibitors, but not because they have some protection against inflammation or COVID. In fact, they may suppress a little bit of immunity and predispose to other infections. So, but because of the easiness of control of blood sugar levels with the once daily dosing, in fact, there is a study by Umpiras et al. Using sitagliptin as a top-up to basal bolus insulin in hospitalized patients. Though I don't use it for hospitalized, and I'm not recommending it for hospitalized patients, I think adding DPP4 inhibitors to insulin will reduce the number of boluses insulin that you'll have to give. So my suggestion is if mild to moderate patients you are managing at home, best insulin to give is glargine, and you can give some DPP4s and some sulfonylureas to manage without bolus insulin because bolus insulin is definitely associated with hypoglycemia. So the short answer is yes. In mild and moderate cases, please use DPP4 inhibitors, whichever it is. I don't choose among the drugs.
Thank you, sir. Sir, nowadays, we are having issues of fungal infections. I mean, especially, I mean, for the COVID patients. And because we are now using steroids and steroid reduce hyperglycemia, and again, due to reduced immunity, and also fungal infections are actually increasing. I mean, especially that mucormycosis. So, how we can manage a diabetic patient whom we are starting steroid, and how, what message we can, or what are the suggestions we can give to that patient, sir?
So two things. One is that you can't escape from the mucor fungus because it is a ubiquitous fungus. It is a fungus that is found in the soil, in the nose and the mucus, even in the air of healthy people. It is there in our sinuses mostly all the time. This is what I could read and understand. Again, I'm not an expert. But in people with diabetes and people with uncontrolled diabetes, sometimes people who are on desferoxamine therapy, which is of course rare, especially when there are diabetes with ketoacidosis, and when there is steroid suppressing or immune suppressing immunosuppressants like steroids, then the risk of mucormycosis can occur. Some of these other drugs used in COVID, which can actually which can actually be given as an anti-inflammatory, can also cause worsening of mucormycosis. So my suggestion to people is that if you look at it, uh, even otherwise, mucormycosis is very common in uncontrolled diabetes, and even in India, mucormycosis, India is a significant contributor to that. Now, as many of you know, uh, invasive mold infections in the ICU has always been there. There is COVID-19 associated pulmonary aspergillosis kappa, and that has always been there. But in addition to kappa, there is mucormycosis risk which is emerging. Now, most common manifestations of mucormycosis are the rhino-orbitocerebral and pulmonary. suspicion is very important, and subtle clinical clues, pain on the maxillary area, a small necrotic eschar on the nasal cavity or oral cavity, some suggestion of ocular or cranial nerve involvement, and of course, pulmonary mucormycosis will give you typical radiologic uh, function. And therefore, there is no biomarker for mucormycosis. So if you want to diagnose it, it has to be clinical, and of course, there is rapid and diagnostic tests such as a KOH mount and the calcofluor strain and biopsy and all that. Once you have mucormycosis, you need to give antifungal, surgical debridement, correction of blood glucose levels. Amphotericin B has always been the standard treatment. But the problem is that some of the COVID patients may have acute or chronic renal failure. And therefore, you may have to, if they have multi-system failure, they have nephrotoxic, then you may have to look at the newer antifungals or the other or non-nephrotoxic alternative antifungals like osaconazole or isavuconazole or some of these new conazole. I'm not an expert on this. Uh, so surgical debridement done early is the best way to take care of these patients. Now, it's important that uh, some adjuvant drugs, caspofungil, Defera, Cirox, statins, aspirin, hyperbaric oxygen, and it requires a team approach. So, in Indian study, uh, the many Indian science studies are saying that the cost because of the morbidity and prognosis, this is the source of anxiety for many patients. Mortality is roughly about 50%. So instead of waiting for this to happen, I think the good news is because I know the media is overhyping everything. But in terms of mucormycosis, I feel there is a good opportunity that media has done because many people are now calling me, doctor, my sugar is 400, I need to control sugars because I'm worried about the black fungus. They are calling it black fungus. So I think this is a good thing the media has done. Usually, I don't like media projecting all these negative news all the time. But one thing it has done here is that it has actually really gone ahead and it has showed people about this why you should not use why you should control glucose and why you should restrict steroids. So these are some of my thoughts. And remember, I am an endocrinologist, so my knowledge may be really limited as compared to you physicians. And if any senior physician is here who knows about mucormycosis, please feel free to share.
Thank you, sir. Sir, maybe this is the last question. Sir, what can be the glucose goals, target glucose goals? I mean, fasting or PPG. I mean, patients who are on steroid or in during COVID, sir.
Uh, Very simple it is. If patient has got COVID and you're managing remotely, the blood glucose levels should be like the blood glucose of a person admitted in your hospital ward, which means fasting up to 140 is okay, postprandial up to 180 is okay. As long as all the sugars are below 180, you are in the safe zone. Remember, in the ICU, we are looking at a little more stricter control. We want it to be between 140 and 180. But in the home setting, fasting below 140, khane ke baad below 180 is considered okay. Now, very old patients where you are worried about them getting hypoglycemia. Recently, we had a patient who called me because on teleconsultation and she's alone at home. Her one daughter is in England and another daughter is in Delhi and she's alone. So these patients, you really feel sad for them and you don't want very aggressive control because they may get hypoglycemia and they're alone. I mean, in a flat, if you're alone, sometimes even neighbors may not know if you get hypoglycemia. So go relax on these patients. Go put your glucose control relax. So even accept 200 or 220 for these patients because one hypoglycemia may be really fatal for them also. So in those patients, I don't mind sugars going little high, 200 or 220, because if the blood sugar is below 220, the neutrophil function and the antibacterial and the immune related functions of WBCs are not compromised as long as the sugar is below 200, 220. So up to 200, 220, you can go in elderly people prone to hypoglycemia. But if young people or middle-aged people or slightly older people, I am 51 years old, so I consider myself slightly older person or maybe a little younger than the older persons, whatever it is. So maybe in such people, below 180 should be the target. But hypoglycemia, very old people alone at home, up to 220 is okay, or even you'll have to take a call depending on that. Always, it's important for them to buy a good glucometer. I'm not recommending any glucometer, I can't recommend, but always tell your patients to buy a new glucometer and the latest model. Because otherwise, you are dealing with 3-year-old glucometer and you don't know how good it is, and you are again struggling. So patients call you, please tell them now with COVID and all that, you please buy a good quality glucometer, a new one, and you learn it so that we can believe the reports. These are some practical points which I found very important. Also, another practical point which I use is that after COVID, many people are having a lot of weight loss and tiredness after COVID. Their nutrition intake is also not good. So please make sure they increase their protein intake. And I don't believe too much in protein supplements or protein shakes or fake shakes or whatever it is. But in this setting, I think protein supplements have got a good role. So using a diabetes specific nutritional supplement will help them recover a little better from the post-COVID asthenia, fatigue, weight loss, cachexia, sarcopenia, etc. These are some practical suggestions, but you'll have to look at other factors like renal function before you give these protein supplements.
Thank you, sir. Sir, you raised one important issue about this glucometers. So usually, I mean, there have been, I mean, many cases. I mean, the calibration and all. I mean, over the period of time, actually, they tend to give, I mean, varied readings. So, is there any guidelines or any recommendation when to change glucometer?
So I always say that if the glucometer is, first of all, it's important to use a glucometer which has got some sort of clearance. You can look at a CE mark behind it, or whether the Indian regulator has cleared it. That is number one. Second is, no point in getting a glucometer from some foreign country. Third thing to remember is some glucometers from foreign countries, they give you the capillary blood glucose. But the newer glucometers which are available in India, they adjust it for the plasma and give you the glucose control. So if you buy a foreign glucometer which is giving you capillary glucose, and if you use an Indian glucometer which is giving you a plasma glucose, remember plasma values are always higher than the capillary values. So you will be in trouble. So always I tell them, you buy an Indian glucometer, don't use the glucometer sent by us, because I cannot read the book and find out if it is adjusting for capillary or not, and sometimes that information is not there. So buy a glucometer, buy a latest quality glucometer from any of the good companies, and also at least once in a month calibrate it with the lab. So whenever your blood test is taken from the lab, while somebody is collecting the blood, just at that time take a small drop, put it on your glucometer. Now all glucometers will give you a between 10 to 25% error. At higher levels, this can be 30%. At lower levels, it should be less than 10%. So the error rate will go up when the blood sugar is high. So you should keep all these in mind when you tell your patient to procure a glucometer. But a glucometer is must in today's world. Earlier, I used to recommend glucometer only for people on insulin or sulfonylureas, but now with this pandemic, I teach every patient coming about glucometer. I tell them to buy, because who knows when they are going to get uh, the COVID infection, and when they are requiring steroids, and if that time they may be too sick to be trainable. So better to train them now itself. That is very important. To having a glucometer in advance, very important, I feel.
Thank you, sir. I guess, sir, that was the last question. Any other person, please, if you want to ask any question, please unmute yourself and ask Dr. Nikishan, sir. Okay, sir. That's also. I will hand over the. Definitely, sir. Thank you, sir, for this wonderful session and all those practical tips, sir. Lokesh, you there?
Yes, sir. Yes, sir.
Okay. So, sir, now I hand over the session back to Lokesh.
Yeah, thank you very much, all the doctors and Krishnan sir, for such a valuable insights and such a good session wherein we were able to talk about some practical tips and how to keep yourself positive and your patients during these tough times. Thank you, sir. Thank you very much, and thank you all of you. And on behalf of Mankind Pharma, would really thank and appreciate your efforts that you came and you attended this program. And I believe you must have gained something out of it. And we'll be soon looking forward to you in another program with possibly Dr. Unikrishnan sir only. Thank you so much to all of you. That'll be all. Thanks a lot. We'll see you soon.
Thank you.
Thank you.
Good wishes to all delegates, and good wishes from me to all the delegates and their families for health and happiness and for remaining safe during the pandemic. I enjoyed discussing this topic.
Thank you, sir. Same to you, sir.
Thank you, sir.